Welcome back to the second half of our research grand rounds. We'll have a second presentation by another exemplary educator in our Department of Family Medicine, and that's Dr. Christine Rivet. And she's a family physician and educator at the Civic Melrose teaching unit. And I've had the pleasure of working with Christine since I actually first started the department in 2011. And Christine was very instrumental in building the essential teaching skills, part 1, which is sort of a core piece of our faculty development program within the department. She has also got an interest in skin problems. Okay, and and this is something I didn't know, in 2008, she obtained a 1-year diploma in practical dermatology from Cardiff University in Wales. She currently teaches the procedural clinic at the family medicine, the Civic Family Health team, where a number of patients are treated for skin cancers, and they're diagnosed and treated there. And since 2010, she has a weekly skin disorders clinic to teach residents about diagnosis and management of common skin problems. Christine is also a recipient of a prime research grant, and she'll be speaking to us today about that. So, Chris, without further ado.
Thanks very much, Doug, and thank you for adding. I didn't put that in my bio about the essential teaching skills, and that was a wonderful beginning of getting to know you. So, let me see if I can start this off. Maybe Anne can give me a hand here.
Just this one.
Okay.
Yeah, this one.
This is as big as it gets, isn't it? Yeah, okay. So this is my topic. Does a structured curriculum and a procedure clinic help residents diagnose and manage skin cancer compared to the opportunistic method that we've had so far? So first of all, no conflict of interest, and I want to thank Doug, who has been a big support. I'm not a researcher, and I feel a bit like a fish out of water even presenting here. And it's been really nice to have somebody like Doug with his friendly approach make me feel like, okay, maybe I can do this. And Parad is my co-investigator. I have known a long time. He's now our unit director, but I got to know him when he was a long-haired medical student, then a resident with me, and now a faculty at our place. And Joe Burns has been a big help with this, and appreciate you being here today. Joe, Joe will no longer be available to those of us who are prime grant recipients at the end of June, which is a good thing for Joe, but a sad thing for us. So got to get every bit of help I can get till the end of June. And Jim Walker is a dermatologist who I've learned a lot from, and he's been very helpful to validate what I'll show you in a moment about our photo quiz and so on. So it's been really a good association. And so I'll give you a bit of background about my interest, is that when I was first in practice, I saw a woman who had a Band-Aid on her leg, and she was in for a physical. I said, well, let's take this off. And I thought, oh, this is bad. I'm not sure what it is, but I'm sure it's a skin cancer of some sort. And it was a melanoma, something that I hadn't seen before. I knew this was bad, and I didn't see for years afterwards, but now I'm seeing almost every week, partly because of my special interest, but just because the incidence has gone from 1 in 1,500 back in the 30s to now 1 in 63. You could say, okay, this is in the US where there's all those southern states, but we're seeing a lot of it in Canada as well. And we haven't been trained very much. Residents tell me when they come into the Family Medicine Center, they've had maybe a week, maybe a day about skin problems during their training. And so what could be done to make them better prepared is something that interested me, and I read about it. And so far, the interventions to help family doctors learn more and treat more skin cancers has been very little. 12 minutes for some, and up to 6 hours, but nothing that's been longitudinal. In fact, when I asked the then director of the library at the College of Family Physicians, she said there were no longitudinal studies that she could find about teaching things about skin cancers to family doctors. So, let me just backtrack a sec. So, for Ad and I, we decided that we would look at our longitudinal training during the 8 months of family medicine to see if that would make a difference. If residents, from the time they came in, to see what their level of training was then, in the middle of their training at the end of 2 years, did they know more? Did they feel more comfortable? But were they also competent to recognize and treat skin cancers? So what we did is create a survey to see what their knowledge was at the beginning of training, like I said, in the middle, at the end, but also a photo quiz that shows them photos of skin cancers or skin cancer lookalikes, and see if they could say what this was and also what they would do with it and what was the ideal treatment. And so our study group were any of the 60 incoming family medicine residents throughout the department. Some came from our training site and the other 3 big training sites, and some were in the community throughout Ottawa and beyond. And we divided them into our training site where we would have the intervention, the Civic, and all the others we considered non-Civic residents. So what we did, and what we had been doing for a few years, but we hadn't formalized it, was every 2 weeks, the residents got together in what we call our procedure clinic. And for the first half hour, there was an interactive presentation. And I must say, I was glad when you were talking about the residents and using their phones, which is a common thing. They are gently put on the spot, so they don't look at their phones because they know that they're each going to be asked this slide, what would they do? And they know that if they listen to their colleague, it may help them answer the next slide. So we've had good interaction and participation. So there are 16 topics, so it's half an hour. Then for the next half hour, we look at letters, referral letters from our colleagues about patients that have spots that look suspicious to our colleague, and to see and discuss what we think this might be and what we would do with that particular patient's problem.
Sorry, Christine, can I ask, are you
Yes.
getting referrals from your colleagues within the clinic, or do you mean you're a center of referral within Ottawa?
Most are from our own center, the Civic. Some come from, and please ask questions as I go along because this isn't a long presentation. And some come from others like Primrose, Riverside, so within the department. And then to make the residents feel more comfortable, the next part is real patients. So for the rest of the morning, in pairs, they will see a patient, look at the spot or rash they have, and say what they think they would do, and then ask myself or my colleague and co-investigator, Dr. Mutamadi, what they say, what they think it is, and what they think they would do for it. And we've learned from time when we were not as vigilant, that we would come in the room and think, oh my goodness, you've already done something to this patient. Well, that was way, way in the beginning and did not persist, but do you have a question?
Oh, just for clarification, because I know not everybody is familiar with the training program.
Yes.
Because it's a 2-year program, yet only 8 months family medicine. I wonder if you could.
Yes, thanks. That's right. It's only 2 years of training, but our residents will come for 2 months in family medicine and see family medicine patients. Then they will leave us for a while to do an emergency month or an internal medicine month or a pediatric month, and then come back to us for an additional 2 months. And that happens 4 times during the 2 years, so for a total of 8 months. Yes, thank you, because I feel like I'm in my own center, but of course I'm not. So the non-civic residents would have the usual opportunistic training, which can vary. It may be that a patient comes in for one thing and they say, well, they're in there, what do you think this spot is? And that sort of thing. So opportunistic training is very useful, but because it's opportunistic, you can't cluster a bunch of patients with certain problems and have that repetition of seeing them on the same day. So this is a question for you. Because I'm not used to doing research, I did with Doug's help and get ethics approval. But I was told that I could not be the main recruiter of residents to get them into the study. And I was a little bit disappointed about that. It makes sense to me. I understand why, so there's no coercion. But at the same time, I thought, oh, if I could be in there, some of them know me. Of course, there's that positive effect. So I don't know if there's any way around that. But in terms of getting recruitment, I think it decreased the numbers, which I'll show you in a moment. So I don't know if anybody has. Yes.
So this is recruitment of residents?
Recruitment of residents to participate.
I think your point about, them knowing you, that they're likely to say yes, that's a good point. But somebody else could be reaching out, and if they say, oh yeah, I know Dr. Rivet, I know the reputation, they will still take part. But I think the most important thing is for them to feel like you won't know whether, they've said yes or no. Or, obviously you will if they don't come.
Yes.
But yeah, I think it is
I know.
So the way we got around it, Chris, is I had collaborators, right? So Kelly, of course, who was a fellow, and their education was not in her hands, did most of the recruitment. And then we also used Joe and Doug when we were recruiting faculty. So I think it's a very important thing because our power with the residents is so significant that I even tell them specifically when they're working with me, I tell them, I don't know who's enrolled because I actually don't remember. And I think it's extremely important for them to feel comfortable.
Yeah, no, I agree because they were responding to a photo quiz, etc. And I'm sure it would affect, but it's one of those necessary evils, I guess. So they did 2 things. A survey, how much did they know about basal cell, squamous cell, melanoma, all 3 groups of skin cancers? Had they seen it? Had they seen it treated? Had they treated it themselves? And then the photo quiz to show them either skin cancers or lookalikes and to answer those questions. And I realized afterwards, I think we all get passionate about our own study, and things being too long is a concern too about them spending time. So here are, and thanks to Joe for putting the next few slides, the numbers together. So I don't think this is going to work. So here you have the 3 different times. Initially, we had 25 residents who responded, who did both the survey and the photo quiz. A year later, there were only 12, who did the survey and 9 did the photo quiz. And at the end of 2 years, it was lower still. So the response rate was not high. The photo quiz, where they would say what they thought the skin condition was and how they would treat it, so that first column, the Civic only, at the beginning, 61% got the correct answers, non-Civic 58%, so quite close. At the beginning of second year, same thing. Civic, where they got the training, 69%, non-Civic 63%. At the end of residency, very small numbers, 76% at the Civic, where they had the training, got the correct answers, and 57% for non-Civic. So these are raw data, small numbers. If they were big numbers, this would potentially be impressive that the training made a difference. If you separate the photo quiz into diagnosis of skin conditions and skin cancers, and I'll show you in a moment for the management, so this is changed around. The Civic, for diagnosing melanoma, 69% got the correct answers at the beginning of training, 100% in the middle, and 100% at the end. Non-Civic had 72% correct, so close to the same, 83% in the middle, and 100% at the end. So you could say there, well, does the training make any difference for melanoma? Doesn't look like it. BCC stands for basal cell carcinoma, SCC squamous cell carcinoma, the 2 most common types of skin cancer. And at the beginning, the Civic were less than the non-Civic residents, 25% versus 48%. And if you skip to the end, it looks as if training may have made a difference. Again, very small numbers, 75% yes.
Do people see their scores at the end of the photo quiz?
They don't. They later got the answers. Joe, I think we sent that, it was several weeks later.
That's what I
Right.
They received the answers, but they didn't know their individual scores.
Yeah.
That's good. So it was teaching, or like you sent them the answers, so.
Yeah. And so that was for diagnosis. For management, again, the same 3 major skin cancers. For melanoma at the Civic, at the beginning, 40% got the correct management answers. At the end, 65% were correct. For the non-Civic, it went from 37% to 25%. For the non-melanoma skin cancers, from 25 to 75 for the Civic, and from 50 to 75 for the non-Civic. So this makes me scratch my head a bit, because if they don't get the right diagnosis, but they get the correct management, anyway, it doesn't quite all go together well. And this was something that Joe and I talked about, which is that in the survey they were asked, how many of you have seen a basal cell cancer? And how many of you have seen the treatment or actually treated? And so this kind of made sense to me, that at the beginning, 20 had seen a basal cell cancer and 11 had treated it, so more seen than treated. But if you look, then that was the beginning. At the middle point, 5 had seen, but 10 had treated. And Joe and I postulated, well, maybe it's because if they said, oh, I've more than seen, I have treated, possibly is, so it makes me realize you have to make the survey really clear. And we had shown it to a few people, but this surprised us. So, challenges and limitations, small number of responses. How can we improve on this? inability to speak to the residents directly. We've talked about that. And how to create a survey with terms that are really clear because of the example I had given you. So these were things that came to mind. And I thought I would just show you, because we have 16 teaching sessions, so you could see what they are, and an example from the photo quiz. So the initial session is the residents see a video, and I agree with Teresa, showing something very short. There's a technique called a shave biopsy. It's about 1.5 minutes long. Then another type of procedure, a punch biopsy, again about 2 minutes. So they're nice and short and I think easy to absorb. So these are from the American Academy of Dermatology. Our own Bruyère physicians, that was at the time David Ponka and Charles Charnowski produced some videos that used to be on the Canadian Family Physician site, are now difficult to find, but they did some very good videos, and residents like to watch the videos. We show them how to do clean and sterile technique and so on. So these are they number 11, but some are 2 or 3 sessions on melanoma and other types of skin cancer. And here's an example from the quiz. We take a lot of our own photos of patients with their permission and use them for teaching, but the dermatologist Jim Walker provided his slides so that our Civic residents wouldn't have the advantage of seeing slides they had seen before. So this is a 65-year-old man. He's got a scab on his nose, and he had a previous basal cell, and there's a scar there. And so the question is, what's the most likely diagnosis? And the correct answer is C, basal cell. And what's the best treatment? And there's a number of answers there. And Mohs surgery is not available everywhere. It is available in Ottawa, but is the
What is
treatment.
Mohs, just briefly? So,
Sorry?
what is it? Like,
Oh, what's Mohs
Yeah.
surgery? I spent a day with Dr. Gillian McDonald, who's the Mohs surgeon in Ottawa. She's a dermatologist, and what they do in places where you can't afford to lose a lot of tissue, like the nose, the ears, the lips, they will take a piece where the cancer is and then look at it right away under the microscope. So if it's all gone, great. If not, another small slice is taken, look at it. So it's an all-day process for the patient, but they don't lose half their nose, which is... So that's the end of my presentation, but I would appreciate any comments as a novice at this. It has given me, I always respected researchers, but it's given me a greater appreciation of all they do. So, thank you.
In terms of the ethics board, another way to maybe not have to deal with that is have that as a quality improvement project, where you don't need ethics approval, I think. So you could sort of look at your residents, time just to see how competent they are, and then develop an a program to improve their knowledge, and then measure it after to see that your intervention for quality improvement has worked. So, it's not a research, but, you can accomplish it. I don't know if Doug has any comments about that.
Yeah, absolutely. I mean, when you do this as quality improvement or evaluation or what have you, I mean, it's that point you just say everybody is doing this, and then you have that full participation, and you don't have the attrition.
and you don't have the controls.
Right, you don't have that as well. Okay, so that's true, and often, that's something that's encouraged before venturing down the road of a project, because then you see little things that come up. And actually, I just had some questions. Okay, this is around knowledge, like in knowledge attainment, but there are some things I think that certainly came out of your study that you may now consider looking at. And one Simone brought up is that element of feedback, right? You know, about when that feedback is received and what form it's received. That may be something beneficial for following up. I was also interested when you said you were really scratching your head around diagnosis and management, right? Like, why were there these discrepancies? Is there something that you could tease out around the diagnosis and management, right? And then finally, just the opportunities that exist within a clinic, within your procedural clinic, versus, you know, just the opportunistic parts, you know, the opportunities that come out elsewhere where that clinic isn't being run. And you know, there's certain different angles I think that maybe you could look at. But, yeah, certainly, I mean that issue around recruitment. I mean, so many educators, you know, have this issue, and yeah, it's about, and again, looking at looking at studies, either doing an evaluation or quality improvement first, or then designing a study where you're not going to fall into that trap of the dropping attrition, attrition rates. And,
Can you, if you don't get ethics approval, I thought with our residents, the FMRSP, the residence projects, that you cannot then publish.
That's the issue. Yeah, that's.
Yeah,
That's the proc. That's the.
There is, it's a little, it's yes and no. You could publish it as an evaluation of a program, which is what you're saying, program evaluation. So you can, I mean, but if you intend to publish, going about it this way is a little bit of the back door. If the intent is to do, a project that you're going to want to disseminate, it is research, but it's perfectly acceptable and really desirable for us to evaluate anything that we do. And so, and we wouldn't want to get ethics approval for all of that, but if we find something that's particularly interesting and then we want to publish, then we can get special dispensation to publish. So I have a couple of, yeah.
So no, I was just going to say around that, I mean, there's certainly not like medical education journals, for example, you'll see on some sites, the reputable journals is that we do not publish, program evaluation. Like that'll be very clearly stated. However, there are other opportunities for disseminating, which certainly encourage local programs, right? So you publish your local program evaluation. So there are different routes to go. But if you are publishing in the peer review medical education type journal, then you'll want to go through the procedure that you did.
Perhaps also if you do the quality improvement project, it might help you if you want to get a grant to do your real study, because you've already got some sort of evidence that it works.
So I have a couple of suggestions in terms of enrollment. So if you put yourself in the potential, the target audience, what are my pros and cons? So what are my risks is that I won't do well, and Dr. Rivet is going to know how bad I am. So it's often really important to be clear that only, a research associate who will see the original data, and all data will be de-identified for analysis, so that your supervisor, the study lead, blah, 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 will not know the results. That's important, because I think that's a hesitation. Do I really want to take a chance at not doing well, and then somebody can look at me and say, oh, or you couldn't see that melanoma. So I think really being clear, that's one. and then the other aspect is the what's in it. So that's the risk, and what's in it for me is potentially that educational aspect. So we will actually provide you, although you have to be careful in providing that educational aspect to the control arm, which is going to then, make a difference. The other point that you raised that is so important, and it's a message we really want to give to all the FMRSP supervisors, because the residents come to us with often, I want to do a survey to evaluate, intent, or to evaluate competence, knowledge, all these things. And often they feel, well, nobody's really done that particular question, so I'm going to develop my own survey. And it's really, really, developing a survey is an art in and of itself, and the researchers don't even develop their own surveys. We always, except if this is the field we're in, like Doug, you'll do that because that's the field you're in.
But that's
the study
itself.
That's a study in and of itself.
Yeah.
So I always encourage our residents to start with an existing survey and modify a few words. And we don't know that, but that's a message we try, because what percentage of our residents do surveys? It's huge. They all want to do surveys.
Yes.
And then I remember working with a resident who said, and then we worked together, and then we found one, and they were like, oh, that's perfect. All I have to do is change that word, And so, because people would have gone through the experience of saying, oh no, they've read that question as this or that, or so.
Yeah.
So that's, I think, really important to sort of tell our colleagues and our residents.
And I looked, but probably not hard enough to.
Well, you were looking probably for something specific to this, but you want to look, for something around like any kind of learning. It doesn't have to be dermatology, but something in it, there's context, and there's all these things, or the way that it's taught, or that can help you select the appropriate survey, and then you just have to change a few words.
Yeah.
So that's the other thing, is that, we don't find the one we would use directly, but often in our fields, you'll see modified from. So we'll use something and modify it. Yeah, so that's something, a general comment.
I'm putting my teacher/clinician's hat on. If you pull the data, the results that you showed, the 75% for both group versus for non-cancer, the non-significant cancer versus melanoma, I actually find your result very interesting. So even though they couldn't diagnose, they knew their limit. This is above my pay grade, I'm referring, right? I mean, I think that's, so you have actually achieved a tremendous educational outcome, which is bad, not so bad, right? Your melanoma, they actually did way better than your control group, because they could say, oh, this is a melanoma, get them going. The less of significant ones, which are the basal cell and squamous, they didn't know what it was, and so they thought, not pretty, I'm referring, which is still an excellent outcome that essentially you want your residents to know. And when you translate it to patient relationship, your resident could actually reassure the patient and say, this is not that worrisome, so 6 months wait time is not that much of a deal, whereas your control group, who actually didn't know what the diagnosis was, they just knew it's not their cup of tea, can't reassure the patient. So the patient walks away anxious, oh my gosh, I got a cancer, the doctor couldn't even tell me what it was. So I actually think your education is delivering the outcome that we're looking for. It's how you look at it. So I wouldn't scratch my head very much if I were you, because congratulations, you have achieved a very important outcome. Joe?
To expand on that a little bit too, we saw it in the non-civic group, in the basal cell carcinoma and the squamous cell carcinoma, even though in the end they both had 75% correct for the management, in some cases in the non-civic group they had the diagnosis wrong. And so sort of the challenge in how to grade the quiz.
Oh.
Yes, that's
Because
exactly.
in that case, they might be getting the management questions right, but they don't, because they're two-part questions, so they might misdiagnose a lesion, and then they just happen to choose the correct answer. So we think, even though the numbers are both 75% for both, we suspect that the non-civic group is actually still worse at managing those cancers.
That's right.
And
So you might want to have a question that takes the two into account, right diagnosis
Exactly.
and right treatment.
And,
Yeah.
and it makes a huge difference, Joe, because if I'm just writing down, you know, to my local dermatologist, basal cell, please see, and it's actually a squamous cell, right? They triage that differently than if I had truly written squamous cell, because I think that's the part that is really important. So in fact, your group was able to write and advocate for the patient, even though they all refer, their referral is much more effective. So if you look at it from that perspective, your group did better than the control, and it's very important.
You might shoot me for this question, but I think the two things we heard this morning could be combined really nicely.
Yeah,
Like this is a really nice Prezi kind of
this
thing.
is beautiful.
Well, I was saying.
It's like totally crazy, because it's all pattern recognition.
Well, no, and it's
Oh, it's
recognized,
all
and you give a yes or
Yeah.
no answer, go back to the picture,
That's
And for
because
dissemination.
it's not
procedure.
a technical skill.
Yeah, I was saying that.
And you have all their photos, you have your library. Like, we have to spend so much time finding stuff for our present. Like, most of our work is, we have to take picture of people's vagina, and let me tell you, that consent is tricky.
Yes.
So, right, so like, there aren't
It'll be
many.
anonymous.
Yeah, apparently there are a lot of pictures of the vulva, not the whole lot on the vagina, unfortunately. So really, it's very tricky. Whereas the skin, you've got a library of it everywhere on the internet, so you could actually create a Prezi so quickly. And there's no psychomotor work that requires, versus for our procedures, there's a lot of psychomotor that we have to teach them. You don't need much video. It's all pattern recognition. Beautiful. We'll develop it for you.
Yeah.
So is that something you plan to pursue, Christine? Like, do you think you're gonna keep studying this?
Yes, I'm
Okay.
keen, and dissemination, that's why I was saying to Parisa, you know, to disseminate throughout the department and beyond would be,
Because if you know, I think there's a lot we learned from this study that we could really, you know, design the next one to be that much more informative. Because the small sample size, you know, we say 50, 75, and the high attrition, who did we lose? The good, the bad, the evil, you know, like that, the ugly or whatever.
they get so busy, the residents.
So, in that sense, in terms of drawing conclusions, even though we're encouraged, the small sample size and the high attrition is a big problem. But I think that we've learned a lot that we can do, so I'd really be keen on seeing this, because it's certainly encouraging enough that we should pursue it if you're inclined to do that.
And if it's part of the curriculum, and they're not worried that the result comes back to you, the enrollment is so easy, right? As soon as you tell them, get a bag of popcorn, do it at home, nobody will know what it is, right? Nobody will see your result. Like, you actually disconnect your name from it. Then everybody can do it in any program, actually. In all family medicine programs in Canada, right?
They would have just an idea, like, so, I think that's a huge thing,
No, thank you for your comments, yes.
Just for that, when you have a sign, you could have at the beginning just what's your expertise, what's your age range, what's your gender, like 3 or 4 questions at the beginning, and you could have just your groups beforehand and never actually have them to have to input a name.
Right.
Yeah.
Right. Absolutely.
Yeah, well, we tried to keep it anonymous it wasn't,
but I think they
But
need
we
to
have a
know,
huge
even if
range.
you did, that's the big thing around, they need to know that it's,
Emphasizing,
And the larger the group is, the less likely you could pin down who it was based on their age and gender. So it doesn't really matter